Hey everybody, welcome back to another episode of Inside Blood from GC Biosciences. And today in the studio, I am joined by Caleb Gore, founder of GC Biosciences, and by Evelyn Kelly, nutritionist at GC Biosciences. So guys, welcome to the studio. So I think rather than me trying to do an intro, it's much better if you introduce yourselves to everybody. So Caleb, we'll go with you first, if that's okay. Could you just give us an intro?
Nice, and my name's obviously Caleb, as you know. I'm the founder of GC Biosciences. I founded it back in 2013, and I've been working with people that have IBS since 2011. And it's one of the reasons I actually started GC Biosciences. I've got a degree in health sciences, which was heavily leaning into nutrition. And I also got a master's in chronic disease and immunity, which allows me to understand the immune side of things. And I'm also a PhD postgraduate researcher at the University of Leicester, looking at cardiovascular sciences. I'm actually looking at telomeres length effects on vascular smooth muscle cells. I've been working with patients with a functional disorder known as IBS for a very, very long time. And we've introduced this new product called IBS Reset, and that's what we want to talk about today.
Okay, fantastic. And Evelyn, same to you. Can you do a quick intro for everybody listening, please?
Yeah, sure. So my name is Evelyn, and I'm a degree qualified nutritionist. I graduated 2013. And have a really big passion sort of for sports nutrition, exercise science as well. But in recent years, been really working in women's health, and again working with women. You know, we do know that there's a higher percentage of women who suffer with IBS. So again, something that I've got quite a lot of experience in with recent years.
Okay, fantastic. So I think, IBS can be confusing from what I know about it. And it makes sense to start at the beginning. And I want to ask you guys, what actually is IBS, or what isn't it?
We have to talk about. Yeah, sorry, Evelyn. Do you want to go? It's fine. You go, please.
Yeah, that's fine. I'll jump in. So yeah, great question. What is IBS? So IBS stands for Irritable Bowel Syndrome. And it is a functional gut disorder, which essentially means that the gut often looks normal on test, but it doesn't function normally. So structurally, it's absolutely fine. But people will get, symptoms of gas, bloating, and discomfort associated with it.
Okay.
With IBS, the first thing is to kind of think of it as like a functional gastrointestinal disorder, just as Evelyn suggests. But the main type of symptoms that you're going to get with, say, IBS is abdominal pain, bloating, altered bowel movements, and that's when we can start to classify IBS into two separate kind of conditions in itself. You've got IBS-C and IBS-D. IBS-C is IBS with constipation, and IBS-D is IBS with diarrhea. Unfortunately, for those unfortunate souls. Although constipation isn't nice. It also is related to food-related symptom flare-ups. So if you eat a certain food, you notice that might trigger some bloating, some abdominal distension, and problems like that. What else we have to kind of think is that IBS is not a disease. Like I said, it's a functional disorder, and there's certain types of problems that are going on in the gut, and that's associated with gut motility and transit, this visceral hypersensitivity. And what visceral hypersensitivity is, it's a very fancy term, but what it basically means is the neurons, your gut is overly sensitive. And when the gut is overly sensitive, normal gut actions give off significant pain. So if you've got some normal type of distension going on there because you're eating, that can trigger the neurons, and you'll be a bit sensitive to the pain. And that's a very real thing. That is what we see within IBS populations. We're also looking at there's an altered kind of fermentation and gas handling. So a lot of people always notice, and you'll get this. I mean, Evelyn, you'll have this. You'll have patients say, I ate some food, and 2 hours later, I looked 3 to 4 months pregnant. And that's that altered fermentation. And this is something, it's the most common symptom that comes up when I'm talking to people that have got IBS. I look 3 months pregnant after after that. Even guys are saying it to me, and they don't even get pregnant, but they look pregnant. So this is diet, microbiome, and host interactions, and something that we're trying to identify doing some of the tests that we do. The crucial point is it's not a diagnosis of it's not a disease. It's a functional disorder, and it's a diagnosis of exclusion. So what you want to do is you want to be able to make sure that you've got nothing sinisterly wrong. So you want to go down and see the NHS, or you want to go, or your country's healthcare providers, or medical or private medical providers, and make sure that they've looked at to make sure that there's no structural changes that align with malignancy and cancer. Make sure that you're not celiac. Make sure that everything else has been excluded. And then once they've said to you you've got IBS, then that is one of the diagnosis criteria of IBS, is to completely normal structural function and no inflammation, and yet you've got this kind of these symptoms, this abdominal cramps, bloating, pain, all that kind of stuff. So that's what it is. I hope that helps people.
Yeah, I mean, I think it's really interesting that you said a couple of times the fact that it's not a disease. It's you said, what do you say, functional gastrointestinal order. And so that sounds positive. That sounds like a positive thing, because it sounds like there's a route forwards for treatment that's, because it's not a disease, should be easier to, I don't want to say fix, but, like kind of help people eliminate, let's say. Okay, so I mean, you mentioned, Evelyn, I think, or I've heard you say that, maybe it affects more women, IBS.
Yeah.
So who does IBS typically affect? Is there a common profile of type of person?
Yeah, it definitely does affect more women than men. So yeah, that is something that has been highlighted. It's not quite fully understood why, but it's likely due to, being hormone related, as part of that. And it tends to begin sort of late teens to early adulthood in both men and women, but women, would be more likely to suffer from IBS syndrome.
Okay, that's really interesting to know.
Absolutely. Yeah. There's definitely a hormonal interaction there, and we actually can see that in the literature. So you can actually look at the clinical research and show that women do suffer IBS more than men. But that's not to say that men don't suffer with IBS. They do. They absolutely do. It's just that women tend to report it more, and the clinical research at the moment is leaning towards hormonal and differences in the visceral sensations within the gut. That's kind of like where the research is leading to, why women are reporting more IBS than men. Yes.
When you say visceral changes, can you just translate that for me and maybe some other people?
Early on, when you get this visceral hypersensitivity where the neurons are overly sensitive to normal gut interactions, this is what we're talking about.
Okay, cool, makes sense. And then
and maybe that's the hormone I mean, women's cycle, the hormones vary so significantly from different phases of the different cycle. It's all to do with this. It's not very nice for women. I generally have a big empathy for them, and that's why one of the first programs me and you, Ollie, created was an IBS program for women.
Yeah, I mean, I think oh, sorry, Evelyn.
Oh, sorry, I was just going to say, I think it's an interesting point you made as well, Kaylin, where women, I think, do tend to be more sort of open to, like, seeking out medical help or going down different avenues, whereas, I do feel like men as well are kind of less reluctant to seek help. So I also wonder if that's, contributing to why, sort of more women report it and more women are kind of known to be suffering with it as well, alongside, obviously, the research with hormonal health. But I think also women just generally speak out and seek help more as well.
Pick up on that, Evelyn. It's good that you did. Yes, there's definitely that bias, isn't there, where women are more, generally speaking, a little bit more health conscious. They'll look towards getting help more, and men will just kind of, it's a bit of bloating, I'll get on with my life and everything will be fine. And they kind of will leave it to, a lot of men will leave like seeking help to the last possible moment, and they shouldn't be doing that, because as we explained today, there is stuff that you can do to help manage your IBS symptoms.
One of the big things, guys, that I certainly know, because I've spoken to people who've had IBS for a long time, is frustration. A lot of people feel frustrated because perhaps this has been going on for a while. Can you talk about that for a moment? Like typically when you see a patient or client with IBS, what's their journey been like to get to GC Biosciences, to get to you guys?
Yeah, I'd like to take that first because obviously we've been working with patients for a very long time, and the first couple of clients for GC Biosciences were people that were suffering with IBS, and we helped them greatly. Now, I would like to actually take this to describe it as the ideal client for the type of program that we offer, and the reason I want to take it down that road is because I want to make sure that the people that come to us for this service are protected first. So if they've just been having digestive problems and it's only just happened, the first point of call for these guys is to go and seek out help from your general practitioner. You have to do this, whether that's a private general practitioner or whether that is the NHS or equivalents in other countries practitioners. This is the first port of call because we have to make sure that first there are no structural changes and no sinister problems with you. Once you've got that diagnosis of this functional disorder that is known as IBS, that's when we can start working with you. And if you can't find a medical doctor, we have medical doctors that can also, within GC Biosciences, we have medical doctors that can actually do this for you. So if you've not been seen by anyone, you can still approach us and we can get you sorted a squared way. And then find, if you've not got any sinister and structural issues, we can then put you onto the IBS Reset program. That's not an issue. But most people that we will see for the IBS Reset program, they've been frustrated, and rightly so. They've been frustrated with the lack of help, and it's not the NHS's. It's not the NHS. It's not an intrinsic problem with the NHS. It's just because IBS is poorly understood in terms of what gastroenterologists will give to what kind of help they'll give to their clients. So they'll be frustrated and they'll feel like they've not got no help. They might have tried other programs that they've found online, or they've gone to maybe a gastroenterologist and said, try this diet, try this type of fiber, try this, try that, and all that kind of stuff. And what you'll notice and what you'll see is that will help for a short period of time. But then ultimately, the IBS symptoms come back because the patient has either not adhered to it or it's run its course and it's no longer effective. So these patients are frustrated by the lack of help, and they feel like they're at the ends of what they can tolerate anymore. So that's kind of my ideal client, is somebody that has been through the general practitioners, they've got the functional diagnosis, and they've tried everything, and they come to us and we start to give them a bit better of a structure to be able to handle their IBS symptoms. And it's a very, very structured way to doing that in the 3 to 6 months that we have them with us. I don't know if I explained that right. Does that make sense?
Yeah, I think that does. Like Evelyn, have you got anything to add? Because obviously this has been ongoing for a while, presumably, for people who come to see you.
Yeah, absolutely. And yeah, it's a really good point to kind of pick up on how long it's taking people to actually kind of be diagnosed. So on average, it's taking around sort of 6 to 7 years for people to actually get sort of a proper diagnosis when it comes to IBS. And I think a lot of it is, like you say, Caleb, it's misunderstood. Sometimes it can be kind of, dismissed or sort of normalized, or sort of, kind of blamed due to other factors like stress and things like that. And yeah, I think it's a real, issue in our health system at the moment, because especially when we look at sort of, quality of life, and when we talk to these people, which, we do, they often feel, really anxious and scared about going out to do, everyday things with like friends and family, or going out to eat. And it really kind of boils down to a mental health issue as well. So I think part of what we do is to work with the individual and just get them feeling confident that this isn't going to, hinder the rest of their life going forward, that there is solutions, there is things we can do to, really help with the kind of mental health side of it, and just boosting the overall enjoyment and quality of life.
So, guys, what you're saying is you don't just tell people it's all in their head and go away and manage your stress and have a bit more fiber and the general stuff. You go a bit deeper.
This is brilliant. I actually like what you just said, Evelyn. What happens, and it's something we touched on a minute ago, is it's been dismissed or it's been normalized. So they get the diagnosis that there's nothing. So they get a functional diagnosis of IBS. There's no structural problems. And in the NHS, they might be given a leaflet and told to go away, and that's pretty much what they'll get. And that's it. They've got to then manage this disorder by themselves, and that's been like that's the dismissal part of it, isn't it? There's your leaflet. There's nothing structurally wrong with you. We can't help you. Bye bye. That's the dismissal part, and that happens quite often because a lot of people suffer with IBS, and then you've got the normalization of it. Oh, it's just IBS. I mean, that is no way to say anything about, oh, it's just IBS. IBS is a definite real thing with significant symptoms that can literally ruin somebody's life to the point where we've worked with people where they can't get off the toilet. And there's nothing structurally wrong with them, and they can't get off the toilet. And we try to manage their symptoms and give them a structure of how they should eat to manage them symptoms and reduce that problem.
Okay, so that's really helpful to know, to have that insight. So, it sounds like there aren't that many effective treatments, or they're not widely known. So if you look at the kind of typical management or treatment of IBS, what are some of the common problems or some of the common pitfalls that you see when people come to GC Biosciences and they've tried, maybe they've been trying to get help for 6 to 7 years, they've tried multiple things. What typically are the problems you see?
There's three big issues three common pitfalls, I think, when it comes to managing IBS in terms when you look at it from a dietary perspective or a functional medicine perspective, which we're going to touch on to functional medicine later on. It's not my favorite subject. What happens is you have people that overly rely on FODMAPs. So FODMAPs are incredibly useful, and there's a lot of good research on FODMAPs and reducing FODMAP foods in people that have IBS. And this reduces symptoms very, very quickly. I'm going to bring in Evelyn at this minute to ask her, what are FODMAPs?
Yeah, great question. So FODMAPs are essentially, they're essentially short-chain carbohydrates. Now, in most people, they actually absorb perfectly fine. But for people with IBS, they actually ferment and they pull water into the intestine, which then causes that bloating, pain, and cramping that people experience. So they're fermentable short-chain carbohydrates. I'll have a go at pronouncing these. They're not the easiest to pronounce, but the acronym for FODMAP stands for fermentable oligounsaccharides, disaccharides, monosaccharides, and polyols. So these are contained in food. Yeah,
that's right.
But yeah, the thing is with them that they're contained in like some really highly nutrient dense foods. So for people who don't react to them, it's actually really good to get foods in that contain FODMAPs. But for people with IBS, that's the issue. It doesn't handle it as efficiently.
And what happens is so since the research came out, and one of the things is everyone Ollie, you'll remember this, a lot of people, and Evan, you'll probably remember it as well, a lot of people were overly saying, oh, I'm gluten sensitive, I'm gluten sensitive. And it wasn't gluten sensitivity. There is such a thing as non-celiac gluten sensitivity. That does exist, but it is actually in less than 1% of our population that might react negatively to gluten, but not as heavily to gluten as someone that has got celiac disease. The clinical research suggests that non-celiac gluten sensitivity is between 0.5 to 1% of the total population. But then back in 2011 to 2013, 2011 to 2018 or something like that, everyone was like, yeah, I'm gluten sensitive. So you're like, so gluten sensitivity is 90% of our population because everyone was taking gluten out. It was ridiculous. What they were actually doing, as you know, Evelyn, they were removing these fermentable monosaccharides. That's what they were removing. They was removing FODMAP foods that were found in the wheat. And that's what they were reacting to. And often at other times they'd say at the same time, then they'd, gluten was a gateway drug, right? It's like a gateway drug. You remove gluten, you must remove milk now. Now milk goes. And then, then you go on to, now you must remove this other offending food. Gluten was this gateway into all these other gluten offending problems. And don't get me wrong, gluten, like I said, there's celiacs, there's non-celiac gluten sensitivity, and there's FODMAPs within it. But it's because, so if you start removing milk, you're removing another source of a sugar that you might not be able to digest, that's causing fermentation in the digestive tract as well. So these FODMAPs, they're the ones with the non-celiac gluten, they're the ones with the gluten sensitivity that was actually helping people, and then people correlated that with the actual gluten, and then that made this gluten pandemic, everyone not eating it and all that kind of stuff. But the problem that I see with FODMAPs is people get really good success with them, but two things: you can't maintain a FODMAP-free diet for the rest of your life. It's not a healthy thing. It increases food fear. So you're like, I can't eat that because this avocado's got FODMAPs in it. I can't have onions because, so you can't even have an Italian when you go out. It's just a nightmare. But it also decreases eventually it will decrease gut diversity, the microbiome diversity, the bacteria that live in your digestive tract that give you a host of benefits. If you stop feeding them FODMAPs forever, you're going to decrease the diversity of that microbiome. And that overly relying on it, and it reduces as well. Obviously, if you reduce FODMAPs, the key thing that we know is fiber is one of the nutrients. You'll know this, Evelyn. One of the nutrients, or whatever you want to call it, has been associated with so many positive benefits when it comes to disease risks, such as colon cancer, cardiovascular disease. As a cardiovascular scientist, I can tell you that increasing fiber is a really, really good thing. There's so many positive things to having fiber in your diet. And obviously, if you're taking FODMAPs out, that brings down your fiber content for the day or for the year or for however long that you're taking it. FODMAPs is a useful tool to start with IBS, but you have to come out of it, and there has to be a plan to come out of it. And one of the ways that I like to do that is I don't take fiber completely out of the client's diet. I think that's a bad idea. So we'll give fibers that they can tolerate that are not fermentable, such as beta glucans, which you find in oats. Right, which is moderately fermentable, but most people handle it really, really well, and really good source of soluble fiber. And we'll give them, and then what we'll do is we'll take them through this kind of structured way, which we're going to discuss in a bit. I'm keeping an eye on time. But we give them a structure so we can eventually get them back to FODMAPs, and we do it in a way that we can make sure that we're taking note of what foods that they still react to, so we can tell them not to ever eat them foods again if that's the case. That's kind of one of the pitfalls I see as FODMAPs.
So it's like not a long-term solution, but it's an entry point into getting some relief to help people realise there's some hope ahead. I think this is really, really interesting what you've just said, and also really important for people to know, because there is a huge amount of misinformation out there in general, not just about IBS, but about food, diet, nutrition. There are so many fads and trends. There are like between 2,000 and 3,000 different diets out there. There's a tea diet, a sunshine diet, all sorts of stuff. And I think these conversations are really important because it helps people understand from a scientific or an evidence-based point of view what works and has a basis and what kind of doesn't. So what's another problem? What's another big pitfall?
Sorry, Evelyn, I'm going to take just right. So probiotics are a huge problem. Yes, generally speaking, let's just get this out of the way with. Probiotics generally have a poor success rate in clinical studies. So they are overhyped. The benefits of probiotics are overhyped, and they generally don't translate well into symptom relief for functional disorders such as IBS. There are some caveats to that, though. First of all, let's say when you go and have your Actimel or whatever it is that you're getting your source of bacteria from, it's generally an aerobic bacteria. That's bacteria that needs aerobic respiration, right? Now, most of the gut is anaerobic. Obviously, in your digestive tract, there's not much bloody, there's not an oxygen-rich environment. So most of your microbiome is anaerobic. And these lactobacillus acidophilus and this bifidobacterium lactis and all this kind of stuff, they represent about 0.1% of the total microbiome. It is tiny what they represent. It is, and this is why don't get, like I said, we're going to get into it. There are caveats to it. There are some things that we give. I give regularly for IBS constipation. I tell people to take Saccharomyces boulardii, which is a friendly yeast that helps with traveler's diarrhea, and it's been shown in the clinical research to do this. And we find it does really, really well, but it's only something that you use temporarily. You don't use it forever. Use it at the start. If someone's got IBS constipation, give them Saccharomyces boulardii. If they react well to it and it cleans things up a little bit, you continue to use it and you fix the dietary problems, and then you go from there. That's kind of like what we would do. And on the other hand, there's another bacteria, Bifidobacteria infatus and Bifidobacteria lactis. There are specific strains, and that's the thing. You need to make sure that you got the right strain. So the right strain, I'm just going to bring it up here. The right strain for Bifidobacterium infatus is 35624, and MIMBB75. These help really well in constipation. So they help with constipation. So we might give that to see if there is any benefits to the patient, and see if they can get rid of some of their constipation. So there are some small studies that show, and I mean small clinical trials that show the probiotic is safe and effective in these small groups of people. And we might say, if that person fits the relevant criteria, we might say, we'll give you this Saccharomyces boulardii, we'll give you this Bifidobacterium infatus, providing all medical clearance is done, and we'll see how you go with that. And if they get success in that, we might use it. But what we don't do is just prescribe VSL, whatever that bloody probiotic is, with about 200 billion, strains of whatever, and say it's going to cure everything. That's still going to represent less than 1% of the total microbiome in your digestive tract. They're expensive, they're overly hyped, and generally speaking, they don't work well when you apply them to big population groups.
So hang on, are you saying that this is all a marketing ploy to go and...
Oh, no, yes.
What? Oh, no, terrible. Okay, yeah, and also, I mean, personalization, this is another thing, isn't it? That, clearly there are some things that work, but they need to be personalized to the individual. Okay, cool. What else? We've covered probiotics, we've debunked those. Anything else on the list?
Evelyn, do you want to talk about prebiotics? I like to use prebiotics, but I think if people are reacting to FODMAPs, I will use prebiotics to titrate at a very low dose and then titrate up throughout certain duration of time and see how well they start to tolerate them. Do you want to touch on prebiotics? Or?
Yeah, I think I guess it would be good to kind of explain the difference between the probiotics and the prebiotics. Essentially, the prebiotics are essentially like kind of the food, I guess, for the bacteria. So the idea of taking a prebiotic is to kind of help the healthy bacteria flourish and grow. I do think, touching on the prebiotics, I do think one of the best ways to kind of help with that is sort of looking at fiber intake as well, and making sure, like as you said, we're not going too low in fiber kind of straight off the bat, because then we're going to kind of exclude a lot of those prebiotics that are naturally found in food as well. So I do think I tend to recommend looking at prebiotics over probiotics for sure. And correct me if I'm wrong, Caleb, but I believe as well with the probiotics, you have to be very consistent in taking them as well, because if you're not adherent and you stop taking them and you're kind of taking them casually, that disrupts the colony in the...
Yeah, that's a very good point. How I like to describe probiotics when it comes to you have to be consistent, especially you have to be consistent when you're looking at the ones that do actually work. And also, most probiotics, I don't think I've read one decent
You mean prebiotics?
study.
Sorry, just you said probiotics. I'm just clarifying for the listener. Pre or pro? Say again.
Ooh, he was probiotics for that one.
Oh, sorry, that's I'll edit myself out. Don't worry.
Yeah, it's fine. Yeah. So basically, I like to say when it comes to probiotics, with the probiotics that actually do work, you have to be consistent, absolutely. But also, I've not read one decent study that has shown that probiotics will colonized forever. So how I describe them, so a probiotic is like a tourist. You take it and it will remain in the digestive tract between 2 and 4 weeks. When you stop taking it, it will wash out. It's called the washout period, and you'll get rid of it, and then it will no longer be there. So I always say for the probiotics that do work, i.e. the bacteria that do work, that we know work well within the clinical research, I would say they're like tourists. They come in, they boost the economy, and then they leave. That's why you have to consistently take them to keep the symptoms going, to keep the symptom relief or whatever positive benefits that you're getting from that particular bacteria, such as relief from constipation. Prebiotics, as you rightly say, they are basically fibers for the bacteria. That is what they are, and they will feed your own endogenous microbiome, and that's the important. And you have to get different types of prebiotics from different ways. You can't just rely on inulin, right, which is a type of prebiotic. You want a vast array of different types of prebiotics, and hopefully we can get you them within your food. But if you can't get them within your food, we can take a supplement with various different types of prebiotics in there for that.
And I think going back to why we don't want to do FODMAPs long term is because if you actually look at a lot of higher FODMAP foods, they're actually really rich with prebiotics. So things like onion, garlic, leeks as well is a really good example. Like I say, they actually contain a lot of prebiotics and benefits. Yeah, for helping IBS. So it's not about taking them out completely, because again, that's an example of how you would lower your intake of prebiotics, but it's about kind of learning what you can tolerate and what quantity you can sort of manage moving forward.
Okay, yeah, I think that's a really good point. Yeah.
Okay.
Definitely. FODMAP's definitely something that you want to use, but you want to be able to come off a FODMAP diet. You don't want to stay on it forever. It's not a good idea.
Okay, so so essentially that's an entry point, and that's going to hopefully help quite a lot of people in the short term. What comes next? What do people do? They need to do some testing. What's a deeper approach?
We do use a stool test, but we don't use it. So let's talk about traditional medical testing with this functional medicine testing. So traditional medicine testing is what your GP will be doing, what your gastroenterologist will be doing, and they're looking at structural pathologies. Is there anything actually wrong down there? Is there any problems? They're looking for malignancy, any kind of cancer. They're looking for irritable bowel disease. They're looking for reflux. They're looking for an actual problem that they can see, treat, and sort. Then you've got functional medicine. Now, I'm gonna actually pull up the definition of functional medicine. I was having a bit of a chat about this just before. Can I ask you
a really quick question before you do that? Can you just clarify what's the difference between IBD and IBS for anyone who?
Irritable bowel disease is a collection of diseases that have an autoimmune kind of pathology. So it's where the immune system attacks your digestive tract, if you like. That's a very, very brief, quick explanation of it. But you've got Crohn's disease and ulcerative colitis. It's a collection of diseases. So you will definitely know if you've got an IBD, and it's very, very easy to tell through testing.
Okay, and it's different to IBS, obviously. I just wanted to clarify for everybody.
Yeah, absolutely. So going back to functional medicine. Functional medicine is, I'm going to read the description here. Functional medicine is a personalized, holistic healthcare approach that identifies and treats the root cause of chronic disease by looking at complex interactions between genetics, environment, lifestyle, and body systems, moving beyond just symptom management to restore overall health and vitality through targeted nutrition, lifestyle changes, and supplements. It views the body as an interconnected whole, working with patients to create customized plans rather than suppressing symptoms. That's the AI overview from Google. What functional medicine is expensive testing with even more expensive supplements. People often talk about big pharma being a $600 billion industry, which it is, and thank God it is, because we've got some wonderful cures. But they don't realize that the functional medicine industry, such as this, and the basically holistic healthcare industry, is about $2 trillion if you combine everything within that. It's a huge industry designed to also make profit. And I've done functional medicine courses. I've done two. I've done some with Institute of Functional Medicine way back when, and another college online, and it literally is just talking about testing and supplements, testing and supplements, testing and supplements. And most of the lifestyle most of the lifestyle interventions personal trainers and nutritionists are doing anyway. So when it comes to functional medicine, they look at stool tests and they'll use the stool test as a diagnosis of something. So they'll go, you've got dysbiosis, you've got SIBO, you've got this, you've got that. And it doesn't work like that. So you can't take these stool tests that work on algorithm-based kind of scores that are completely, I wouldn't say completely arbitrary, but mostly arbitrary and made up by the labs to sell the testing. And then you'll get this functional medicine practice. So you've got this dysbiosis. Your dysbiosis score is 8, and we need to get it to 1, and that then will relieve all your symptoms. I don't think it works that way. We use stool tests to inform us about the reactive nature of the microbiome. So what is it that people are eating, and how is that impacting their microbiome? And then that tells us how much fiber that they can handle, how much fat they could handle, protein issues. We also use stool testing for different things. So we do look at some sorts of pathologies. We will look at pathogens such as E. coli if it's present and treat if needed. We will look at candida if it's there. We will help. We're looking at parasites like Giardia lamblia, of course. We're also looking at malabsorption issues, and we'll deal with that as well. But the microbiome aspect of the stool tests that we're using to solely inform dietary choices.
Okay, so
to give people a label of dysbiosis and SIBO. They most likely have dysbiosis and SIBO. We know that IBS patients do have these conditions, but that's not what we're using the stool test for. We're using it for a dietary intervention to inform dietary requirements and get them symptom relief, because that's what it's about. It's a functional disorder, get them symptom relief and attempt to change the microbiome through positive changes in their diet. Because the microbiome is incredibly reactive and it's very, very quick changing. It can change in a week quite easily.
So essentially, it does allow you, so like the testing you do does allow you to get to kind of what we might call root causes. Is that fair to say?
No, I don't think root causes. I think what it allows you to do is manage the symptoms that the root cause is causing, and maybe you will be able to change the client's perception of their symptoms as they go through the IBS.
So what I'm
That's
hearing
pretty much what you're doing.
What I'm hearing is it's a bit more complex than just going, oh, here's a label. That's your
here's the dysbiosis. That's definitely causing your symptoms. Let's once we've got rid of that, you won't have no more symptoms.
Because there's so many factors, it's so complex. There's the visceral sensitivity or hypersensitivity you mentioned, hormone implications, etc., etc. So it's not just a sort of cookie cutter thing. Okay, cool. That makes a lot of sense. So I'll just touch on one last point. That's really nice what you just said. Remember, IBS is overlapping problems: gut motility and transit, visceral hypersensitivity, fermentation and gas. Fermentation that causes gas, abdominal distension. This is what IBS is. And we just still don't have the best understanding of why that root cause is. We don't have a good understanding of what that is. And anyone that's trying to sell you something to say we will get to the bottom of the root cause is selling you a dream. Okay, well, that's good to know. So basically, testing is important. Testing is useful, but there are certain conditions for how you use it and how you don't use it. Anything you want to add, Evelyn, on testing?
Yeah, I think it's definitely important to test. And like Caleb says, I think it's going to getting the right and appropriate test done and going to people that are, evidence-based as well with what they do. It reminds me, I do see a lot of people come through with the IgA testing for food intolerances. And a lot of people will come to me who have been struggling with IBS, and as we spoke about previously, one of the biggest things with FODMAPs and IBS is people have fear and anxiety and ultimately end up restricting their nutrition intake down to like very little energy intake and very little foods. And that, contributes to more symptoms of IBS. I don't know, there is a stat, don't quote me on it, but I think it's like 70 to 80% of people who have struggled with disordered eating actually have IBS. And you see it a lot in like physique competitors as well that have dieted down to a really low body fat. So I think with some of these tests, and when you go, they're not fully evidence-based, and people are sort of told, okay, a big long list of, what you can't eat. And it's just heightening that fear and anxiety. And then again, like I say, restricting their food intake, which then kind of exaggerates some of the symptoms they're having. So yeah, I definitely think testing is great, but do your homework, make sure you're going to people that are, evidence-based, with what they do and what they test for.
I think there's another podcast episode specifically around restrictive eating and kind of diets and excuse me, the problems that can cause. I think that'd be really interesting. But for now, what I'd love to focus on is so you have a program called the IBS Reset program at GC Biosciences. And why is that beneficial to a client who's been, let's say, on this journey of 6-7 years struggling? They've been to their GP, they've been to multiple other practitioners, they haven't been able to find any reason for their IBS. They just know they've got a whole lot of nasty symptoms and no one can help them. And then they come to you guys. What do you do differently? How do you help a patient or a client?
So I'm going to talk about the different phases, and then I'm going to hand that over to Evelyn to go a little bit more in depth into the dietary phases. So we have a framework. It's called the IBS Reset Dietary Framework. The first phase is baseline testing. Like we just said, you have to test, but because the microbiome is so incredibly reactive to different foods, we don't want to change your diet. We need to get you tested first. And in that testing, we're obviously going to look at pathogens. We're going to look at inflammation markers. We're going to look at malabsorption. And if you have any problems with them three things, we will sort that out through our medical team. No problem, right? We are then going to look with the dietary wise. We will then have a good amount of information to be informed on what you should be doing on your diet. Unfortunately, this test takes a long time. It takes about 3 to 4 weeks to get it done, processed, and get the results back. Then we go into, while you're doing that, while that testing's gone off, you go into the FODMAP reduction. So Evelyn will put you on a FODMAP diet for 4 weeks. We again get the results back, and then we'll go into phase 3, which is the personalization part of your program, where we use the stool test context, the diet and your symptoms to inform what type of diet you should be using. And Evelyn's going to go into a little bit more about that in a minute. And then we're going to the final phase, phase 4, where we'll start to reintroduce foods that you were previously reactive to see if you're reacting to them still. And we then, if you do react to them, we put them on a naughty list. And if you don't react to them, they just go on your good list. And that's the very, very quick, brief dietary framework. We're running out of time, so I've really gone through that very, very quickly, and I'm going to let Evelyn now talk, because I've done a lot of talking, and you've not heard from the lovely Evelyn yet.
Yeah, so I guess one thing that makes us different, I would say, is also the support you're given along your journey. As you said, a lot of people are feeling anxious, stressed, they want answers, and with our program, we do offer the ongoing nutrition support. So, our clients will have access to me throughout their journey, which is really good from a support standpoint, because to actually implement a FODMAP diet can be quite difficult, so you definitely do need that support. So that's one thing I feel makes us very different and unique. So in those initial stages, we will introduce the low-FODMAP diet. It is very important that you adhere to it, because FODMAPs do have like a stacking effect as well. So the adherence is key, and that's where that support can really help as well. And then moving forward through that journey, as Caleb said, we start to reintroduce the foods back in. Now, one thing that's really important for me when I do work with people is that, again, they don't feel restricted. So we do obviously have resources and tips and tricks on how to flavor food so it doesn't feel restrictive. As Caleb said, we make sure you're still getting, an adequate amount of fiber in. We make sure it's, meals that you can enjoy. We go through things that, if you do have a meal out, okay, how can you combat that? Or if you have friends and family around, we try to make it really personalized to you, so that, yes, we've got a plan and we've got a goal, but we're helping you through that, so you're not kind of living a life of misery while you're doing that along the way.
Fantastic. And I do actually believe I wanted to share with people that we have got some free resources available for people. So if this resonates and if you have been struggling with IBS and you've got some of the symptoms that Caleb and Evelyn have discussed, there is a free 3-day low FODMAP diet that we can share with people. We'll add some links that people can download for free. And there are a few videos, I think, from you, Evelyn, just guiding people through how to run that. And the idea is obviously this is just a very, short-term introduction for people, but it should help to get some relief initially so that people can then go further, go deeper into a personalised treatment.
To discuss what I'm calling the IBS's clinical philosophy. I just want to finish on that. Is that okay?
Yeah, great, go for it. Evelyn, if you needed to disappear, I can edit this bit out, by the way. You could do that, or
Yeah, I better jump off. I've got a call, but all right, thanks, guys.
we'll just stay here, Caleb, and you do your wrap up.
Yeah.
Cool. So we'll make that free resource available, which is the 3-day low FODMAP kind of meal plan, and there's 3 mini videos that go with it. So, Caleb, any sort of final words on this topic?
But the clinical philosophy that we've developed for the IBS Reset program and what you're going to get. And I think it's important for you to understand this if you're going to come over and do some work with us, even if you're going to pick up the free resources or maybe you're looking to buy a different program. This should be one of them kind of criteria that you set when looking at other programs. The first thing is that IBS is heterogeneous, which basically means that there are multiple functional drivers causing the IBS. And the way that people respond to even treatment can vary, right? It's not like if we give this person this drug, everyone's going to react in the same way. There's multiple issues when it comes to IBS, and people with IBS will react differently to diets and medication. That's what we mean when we say it's heterogeneous. There's no single root cause. We don't know the root. We don't really understand it just yet. And anyone that is saying that there is just one single root cause to IBS is selling you a dream. It doesn't work like that. Dysbiosis isn't the root cause. We've looked at it. There's clinical research on it. It doesn't work. It helps, but again, because IBS is heterogeneous, it responds differently to different things in different people. It's so variable. There's overlapping functional drivers to it. Remember that. Diet response is the primary outcome. So your diet is going to help significantly reduce your symptoms and allow us to get you into a better frame of mind to allow yourself to deal with your IBS symptoms. Tests that we do, the stool test in particular, inform us about the dietary needs. It doesn't give us a diagnosis of, especially when looking at the microbiome, it doesn't give us a diagnosis of dysbiosis, small intestinal bacterial overgrowth. It might help us look at what's going on there, but it certainly informs us of what dietary needs are. Your symptom improvement is the one thing that I'm interested in sorting. That's what I want to get sorted. I don't want you having no symptoms. When people say you shouldn't treat the symptoms, you should look at the root cause. If anyone says that to you when looking at IBS, fire them immediately or leave them or whatever. You actually do need to treat the symptoms in IBS because we don't understand the root causes just yet. Sustainability is not aligned to restriction. So we will restrict certain foods. If a FODMAP food comes in and no matter what we do, at the end of 6 months, it's still just this one. If onions still trigger you, yes, you have to remove that. But we don't want to restrict too many foods all the time. It's going to be for the rest of your life that you'll have to deal with this. Not saying that you have to deal with IBS for the rest of your life, but if you can't be on FODMAPs for the rest of your life. That's kind of like the clinical philosophy that we're working with here. IBS has multiple drivers, and people respond to multiple treatments in variable ways.
Okay, well, that's a really good summary. And so, I mean, is it fair to say that one, there's not like a magic cure out there for IBS, and the best you can do is work with people who really deeply understand the clinical side, the research side, the evidence basis, and get long-term relief. So, hopefully people can get to a position where they can return to a more normal pattern of eating, enjoying food, enjoying life, and have a meaningful, significant reduction in symptoms. Is that fair to say?
To develop a dietary framework for the for the patient, so they can sustain that for the rest of their life with reducing the symptoms as much as possible.
Yeah.
And that's the end goal of the IBS Reset program. The end goal is create a dietary framework for the patient, which allows them to have significantly less symptoms, but also enjoy their life and not have to think about IBS. And plus, once they've been through the FODMAP and maybe we have removed any kind of pathogens and give them some sort of relief. Once they've been through 3 to 6 months of that, a lot of often you'll find that the visceral hypersensitivity is not as sensitive, so so when they start eating. I'm going to say normal diet in quotation marks, a normal diet, they probably won't respond to the same way that they was before they started the program as well, if that makes sense.
Yeah, hence the reset, IBS reset. Okay, fantastic. Yeah. Well, I want to thank you both for your time. Evelyn had to just jump off at the end there, but thanks, Calum. I think this has been really interesting to kind of take a deep dive into IBS, and I feel that at some point, probably should do a follow up on this topic because it's, I think there's just a lot of people out there affected by IBS and struggling with the symptoms.
Yeah, absolutely. I think it's better. I hope we will do some more podcasts on this. I think that we've briefly touched on these 4 points today, and you could have 1 or 2 podcasts on each point. I think the next podcast would be nice to look at the probiotics and what probiotics actually work and when to use them. I think that would be really informative for people. We could do a 30-minute podcast on that.
Yeah, absolutely. And we'll get some feedback from people and we'll share that information. All right, so that's it from us today. Thanks for listening, everybody. We'll share some show notes with some specific links to the free resources that we said. But we'll see you next time on Inside Blood from GC Biosciences.